All right, just a few tips about cultures. I know you heard me mention about the middle one there already about central lines used as a last resort and then kind of changing the caps first. Another important point to remember is whenever possible, if the patient is deemed to be showing signs of infection and the doctor is going to order antibiotics to be given, you want to always try to get that culture, whether it's a blood culture, a urinary culture, a sputum culture, what have you, first before you start the antibiotics. Although I will tell you that if somebody's really, really sick, you sometimes do have to start the antibiotics, because a good example is a sputum culture. Sometimes patients just cannot cough up anything that quickly, and they may have a bad pneumonia, and you may really need to go ahead and start their meds. But if you can get cultures for whatever it is that's ordered, you want to try to do those always first before you start the antibiotics. The antibiotics will actually mask the infection sometimes, and then you draw blood cultures a couple hours later and they may not show the germ now because you've got antibiotics in your system. Just a few things about urine cultures. Sometimes that is delegated to a CNA. You want to make sure that you really verify their collection method. You want to either have a clean catch specimen or a clean cast specimen, or if you're getting it from the catheter, that they really used an aseptic technique and pulled the urine from up at the top through the tubing from a portal. And that just ensures that you're getting more of the specimen right out of the bladder versus, something down in the bag where it could be set and been dirty, and have a lot of different germs for a while because it's more dependent. CAUTIs, you'll see some things about this in the hospital. This is kind of when the urinary tract or a kidney infection occurs, when bacteria or other germs kind of travel along the catheter. It's real common, particularly in elderly patients, for them to have GI germs like bacteria that grows normally in the gut. Because think about it, patients have incontinence of their bowels. Sometimes that takes a while for somebody to come and clean it up. There is often opportunities for that fecal material to get in and around the catheter tubing itself and or the meatus. And so sometimes it's not uncommon for you to get those urine cultures and find out that it's a GI germ that's cross-contaminated. Symptoms that the patient would have would be burning or pain in their lower abdomen, fevers, cloudy or bloody urine. Sometimes they'll have urinary frequency, but occasionally they have no symptoms at all. A lot of times elderly patients will show up at the emergency room sick, dizzy, weak, passed out. They're not complaining of anything about their urinary tract. They're running a fever, they get blood work, their white blood cell count's elevated, and then they find out when they get a urinary specimen that they've got a UTI, and the patient themselves may say, I never had any symptoms. So just realize that sometimes this can be vague, but in this case, the key thing is we don't want patients that we've had to put a catheter in then get a urinary tract from that catheter. So there's going to be a lot of steps in terms of how soon do we take out a catheter after surgery. How do we even obtain specimens accurately so that there isn't cross-contamination and end up treating a urinary tract infection that really isn't a real one. But you will see white blood cell counts ordered, urinalysis ordered, and urine culture in these situations. You will hear people talk about healthcare-associated infections. These are ones that are inquired in an inpatient setting that is not present at admission. So, you may not have a reason. In the example I gave you with the person that had a UTI in the emergency room, maybe they tested every other thing on that patient, and a day or two later they think, well, let's check them for a UTI. And then the UTI is found, but the patient has had a catheter in. the assumption then is, well, the hospital caused it. So in that case, there's no payment for that stay related to the infection from Medicare. And so it's very important to really do a grade assessment related to infection potential on everybody right off at the very beginning of admission. These terms, endogenous and exogenous, just let you know from a patho standpoint that infections, a lot of them come from outside the patient, and that's kind of what we're talking about. But patients can also have normal flora that just grows out of control because of some other thing that they're being treated by, and then they really have detrimental infection that's kind of an internal thing. So just make sure that you look at examples of those types and know when would be one be endogenous and when would be exogenous. The main primary wonderful weapon for controlling infection and preventing it is hand hygiene. You can see the stats right there in terms of reducing deaths and also reducing respiratory infections. I will mention that alcohol-based hand rubs, which we use a lot, are usually anywhere from 60 to 95% concentration. So while we want those used quite a lot, just know that there are a lot of alcoholics that are in the hospital and do know, even though this is more of a not the typical kind of alcohol that they drink when they're out drinking, but when they're desperate, they sometimes can resort to using hand rubs and actually drinking it. I've seen it happen. So just keep that in the back of your mind. But it is very, very important that we really are strict with our hand hygiene. We need to use alcohol-based hand rubs going in and out of rooms, before and after patient care, before doing any procedure and putting on gloves to do a sterile procedure. And just remember that some people can be sensitive to those too because of the high alcohol content in terms of patients using them. We do disinfection. You know, you've seen the Sandy wipes that are used. Just know that there's a couple different types of those. Whenever you have a patient that has C. difficile, you're going to use a different kind of wipe that has Clorox in it. And for those kind of patients, you also have to do hand washing because the alcohol-based hand rubs do not work to kill C. difficile. So that's one little stipulation you need to be aware of. Obviously, in ORs and lots of areas, we actually do sterilization of things. And so it just depends on what area of the hospital that you're treating a patient in. Standard precautions, I know you've all been kind of educated on that and know you need to wear gloves when you're handling blood and body fluids, or you're anticipated coming in contact with something towards your body. Put on a gown before you go in and do that type of procedure. And then these are just the different types of transmission-based precautions that you see in the hospital. Be familiar with how and what you wear with those. I will say that when it is a C. difficile patient, you normally will see a different sign that says contact enteric, meaning that it is very kind of specific to GI tract, fecal material, that kind of thing. And in some hospitals, they actually put patients in certain areas of the hospital and not in other areas because of how their immune system is, just to be aware of those kind of things that are done. This was a question I had whenever we had patients that were being treated for C. difficile. You can see how close the patient is to the curtains. And I asked, what about the curtains? And come to find out, nobody had been taking the curtains down in between patients in a particular room. They just assumed they weren't out of the bed and weren't touching them. And that, of course, as staff, we have to touch them with our hands going in and out. And so really think globally about prevention as much as you can. Know what a multi-drug resistant organism is and that patients can be colonized. So you'll hear some people refer to this as MRDO, And you'll see that in the chart. Sometimes you'll see a history of that. Some hospitals will still isolate patients that have a history, just to be on the safe side. But these are microorganisms that have become completely resistant to certain antibiotics. The most common MRDOs are methicillin-resistant Staphylococcus aureus, or MRSA, you'll see that abbreviated, or vancomycin-resistant Enterococcus, or VRE, and then carbapenem-resistant Enterococcus. So look for those, make sure that you're very familiar with those particular things. But when you see methicillin-resistant Staphylococcus aureus, do you think a patient is going to then be given ampicillin? I mean, don't just think about it in terms of methicillin. It's going to be resistant to all of the cillins, typically, like penicillin, ampicillin, a combination of ampicillin and something else. And the same thing is true with vancomycin. And I will say this, one odd thing about it is, because of MRSA, usually the thing that you have to treat the person with is vancomycin. So you can have a patient that has MRSA, then they come in and get treated with vancomycin for a long period of time to treat the MRSA, and then they end up having Enterococcus that is resistant to vancomycin from an endogenous standpoint, because your GI flora has Enterococcus in it anyway, and so they get so much vancomycin that their own body develops infections that may have VRE in it, or get cross-contaminated to the urinary tract from that. This is just a little bit more information about that I kind of mentioned. Usually this is spread by urinary catheters, vascular access devices, and that can be, IVs, central lines, different things like that, and endotracheal tubes. It can also be community acquired. So you may have patients come in and they have got a community acquired MRSA that had nothing to do with them being in the hospital, and so they just need a lot of health teaching and how to really do that same kind of treatment and care, and to stay away from large crowds, and how do they manage not contaminating and causing another family member in the home to get sick as well. Okay. These are just some of the problems with inadequate antimicrobial therapy. And what that means is you're giving somebody an antibiotic and you send them home and you tell them that they need 3 more days of the antibiotic, and they've given them a prescription for that. And they think, well, what's 3 days? That doesn't matter, or I don't have the money. And so they don't get the meds, and so then that germ that's been being fought off by that antibiotic comes back kind of in a resilient pattern, and then they can have resistant infections. There also are some legal sanctions that can be put in place to compel a patient that has TB to get full treatment, and that's just so that they're not contaminating the populace. And then sometimes people will get severe bloodstream infections that go into septic shock because they haven't gotten the right amount of medication, or they're getting the wrong antibiotic, and maybe their cultures haven't grown out what the actual germ is, and so you're kind of treating the infection based on what you think they might have come in contact with. Last of all, this is just a little bit about patient collaborative care. This is your typical assessments. Again, these are some of the lab work that would be important to pull and know kind of what the patterns are with that. This is just showing a little bit about how to manage fever. The biggest thing is get rid of the cause if you can, and destroy the microorganism with drug therapy. Sometimes extra fluids are needed. Sometimes external cooling blankets and things may be used. And then community-based care